The Society of Private Medical and Dental Practitioners is proposing the adoption of co-payment to help resolve some of the nagging challenges facing the National Health Insurance Scheme. The NHIS is confronted with major challenges of claims reimbursement, which is hindering the achievement of universal health care for Ghana. There are also questions over whether with its current structural and operational inefficiencies, the NHIS is financially sustainable over the long term. Are you willing to pay part of your healthcare costs even when you have a valid NHIS card? And is this enough to salvage the scheme from collapsing? This is today's big story with me, Stephen Enti. Now, although the World Health Organization commends Ghana for being one of the countries that have taken important steps towards attaining universal health care coverage, there are still major issues to address. For example, delays and reduced amounts due to errors in processing claims have been a major headache for the National Health Insurance Authority, NHIA. Now, the Society of Private Medical and Dental Practitioners believe these challenges are making the rich actually benefiting more from the National Health Insurance Scheme than the poor. To address these disparities, the group, among others, is calling for co-payments for patients to bear part of the cost of their own health care. Dr. Kwesi Odoi Ejako is the president of the association.
Many methods have been tried to sustain Ghana's health insurance, but in vain. We prescribe to the NHIA and the government co-payments. Yes, we know it is a social health insurance. Clients are prepared to contribute a little for competent and appropriate health services. Co-payment is a payment made by an individual who has health insurance, usually at the time a service is received. If it's a fixed sum, then everybody who has malaria contributes 5 cedis as co-payment. That's the first, one of the methods. The other one is a percentage of overall cost of service. It applies the same way, but this time it's not a fixed cost. It is a percentage. So if the total cost of treatment is 100 Ghana cedis, and the percentage is 10%, then it means the patient contributes 10% of the 100 Ghana cedis. And that's the second way we can work with co-payments. The third is a combination of both fixed sums and percentages. And the last one is called the deductibles. These are things that they deduct at source. Now, if in countries, the OECD countries, in many low and middle income countries, co-payment has been introduced since 1980s as an element in cost recovery user fees.
Right, let's get Dr. Ejako now. He's joining us on the telephone line for more clarity on the issues his association is raising. Good evening, Doc, and thanks for joining us.
Good evening, and good evening to your listeners.
Now, in your press conference today, you cited a 2013 World Bank study which said Ghana's National Health Insurance Scheme, NHIS, could go bankrupt because of issues like structural and operational inefficiency and the effect of Ghana's fragile macroeconomic and fiscal situation on healthcare delivery. Do you not think that such a report is outdated for you to actually use as a basis for the key points that you raised today?
It is not outdated as such. Some of the things may be outdated, but the problem still exists because there are still structural operational inefficiencies. Because we still have a fragile macroeconomic and fiscal situation. Because we still need major reforms. And some of these reforms are supposed to be outside the purview of NHIS. You see, it also, that particular report also warned that the system is too inefficient to absorb significant new resources. And this report came out in 2013. We are in 2015, and it's the same. All these things still hold. Unless, of course, maybe you'll be able to convince me that we still don't have any operational inefficiencies. Because we always hear about this doctor having defrauded, this officer from NHIA having defrauded. You know, everybody is defrauding somebody in the NHIA. So these these operational inefficiencies are still there. Unless, of course, somebody wants to tell me that we are not in a fragile macroeconomic or physical situation. It is still there.
Now, you made two proposals. One is co-payment. Let's focus on the co-payment for now. Now, yeah.
Yes. No. Hold on. You know, our press conference today was very specific to a particular point. And that particular point is we have not been paid for the past 7 months. We need our money. We don't want any other things to come and dilute the reason why we had our press conference.
Right. So
if you really want to talk to us, let us talk about our payment.
No, let's talk. Right, that's fair. Let's talk about your payment. But what I wanted to bring forward was that beyond the fact that you are demanding to be paid, you also made proposals which you feel could help salvage the scheme from collapsing. I mean, you referred to a 2013 report from the World Bank which suggested that the scheme could be at the brink of collapse. So I'm saying that regardless of the fact that you need to be paid, your proposals also are key to our discussion. So let's start with your demand for payment. You haven't been paid for a long time, and your members are feeling the pinch. You have about 316 members. So what? Are you threatening to withdraw services, or what, if you are not paid?
We have never threatened to withdraw services. We signed an agreement with NHIA, not the society, but individual. Sign agreement. And they were promised to be paid after a certain time. So we are saying that we are going to work strictly according to the agreement that we signed with NHIA. After a certain number of days of presenting your claims, you should be paid. And we have not been paid for 7 months. So anybody from the 1st of May, anybody who comes with NHIA card or a card holder comes, if the person is able to pay from his or her pocket, we will see the person. We are not saying that we are threatening to stop work. We can't stop work. Because that's what we do. We work, pay our workers, pay our rent, pay our services, and pay for everything else. So we can't stop working. The only thing is we will stop seeing people who come with NHIA cards. That's all.
And so,
but if you can pay from your pocket, we will see you.
So to resolve this, you're proposing that the co-payment should be formalized in all hospitals, since in your statement you made reference to a World Bank survey which puts the percentage of people who pay for healthcare out of their pockets at 67%. So you think that if majority of people are already paying from their pockets, that it's all right for the nation through the government and the National Health Insurance Authority to adopt and formalize co-payments, correct?
Thank you. I like the way you put it, formalize, because the government is aware, NHIA is aware that there is co-payment going on everywhere in this country, in the public sector and in the private sector. But according to the rules and regulations from NHIA, it is illegal. They know it is ongoing, and they know it is illegal. Those doing it also know that it is illegal. But it is still ongoing. And the patients are prepared to pay for better services. And all other methods have been tried to be able to get the NHIA going. It is only the co-payment that has still not been tried. So we are wondering why they don't want to talk about it. And this is not the first time we are suggesting co-payment. It's been suggested at so many different tables and locations. So we are bringing it back as another proposal for them to think about it. It is a proposal. If they think it's a good thing, they should call us. They should call all the stakeholders, including government service workers and the private service workers, so we can sit down and dialogue,
right,
or talk about it and come up with the modalities of the co-payment. We talked about it before, and we were told it's a social insurance that they are offering, so they can't accept co-payment. But when all others have been tried and they are not succeeding, we believe that we should still go back and talk about co-payment.
Right. Dr. Jaku, we will have you hold briefly and get onto the other telephone line. Former Director General of the Ghana Health Service, Dr. Osei Asare, is joining us. Good evening, sir, and thanks for your time.
Good evening, and good evening to your panelists and to the listeners of your good service.
It's great to hear your voice, pulling you from retirement and giving you work to do. We know that you've had very rich experience as former director of the Ghana Health Service, and constantly our health system faces challenges which experts say is affecting our journey towards universal health coverage. Now, doctors, private practitioners, private medical and dental practitioners are complaining that for 7 months they've not been paid what is due them. Now, the reality is also that the NHIS is faced with a lot of challenges, including, most importantly, delays in payment of claims, etc., etc. What do you see as happening to our health system generally with all these challenges that is confronting the health insurance scheme?
Thank you very much. And let me say that health services will be incomplete without proper funding. Financing is one of the main key services to put in place if we talk about quality health service delivery. And how it is to be done is a challenge to all countries. Even the very rich countries find it difficult to really finance healthcare. It is a very expensive business, and all must be involved in trying to carve out what is good for health delivery in any one country.
That's right.
And we have opted to have a social health insurance as one of them, but it does not take away other forms of healthcare financing. Government, for instance, still pumps in money to pay health workers, to buy equipment, and to run other services. Partners bring in money to help run the system. The health insurance is there first and foremost to make sure that there is equity in the system,
That's right.
especially for the poor. In fact, this insurance is mostly to make sure that no one goes without being taken care of.
But, Dr. Sorry, you've painted a very nice picture about the benefits we get if we have in place a social intervention like the National Health Insurance Scheme. But the private medical and dental practitioners say the inability of government to pay promptly and its inability also to resolve some of the issues that plague reimbursements means that rich people are able to afford healthcare more whilst poor people are unable to afford healthcare because they cannot pay.
Yes, I agree with you in totality. The health insurance system we are running, the social health insurance we are running now has a lot of challenges. And one of them is how to even finance that. The 2.5% that we take as back to finance it seems not to be doing well.
Yeah.
Its management itself seems not to be doing well. And the way we reimburse providers is another big challenge altogether. And we have to take all in totality. When I when I tuned in, I was called and I heard something being mentioned about co-payment.
That's right.
Co-payment is one of the methods of reimbursing providers.
And you support this absolutely, that co-payment is an option government should explore.
We have to look at what co-payment is and what the health insurance system is altogether. You bring in co-payment or cost sharing.
Sharing, that's right.
Control utilization of healthcare services. If when someone is having insurance and they know that they are covered, they can go so many times to get whatever they want. In fact, they can shop, go from one place to the other, knowing quite well that they are covered.
That's right.
So co-payment is basically to make sure that the person who has that card does not abuse the system.
That's right.
And that is what it is for.
I see.
So it is just not a matter of saying that perhaps public sector should do co-payment or not, or private sector should do co-payment or not. You have to evaluate the whole situation about abuse
Absolutely.
of the system and use it to control the person holding the card, not to abuse the system at all. It is not going to give more money into the system to the health worker or to the provider. It is only to check the misuse of it. But you see, what we are talking about here is the ability to reimburse providers. There are many methods of doing that. But I always say that if there is a problem and stakeholders do not sit down and discuss, then the problem can never be solved.
That's right.
In actual fact, you have got a provider, you've got the insurer, and you have got the person who is, the payer and the insurer. The person who insures him or herself.
Right, Dr. Sorry, I beg your pardon. I'll have you hold briefly. I still have on the other telephone line Dr. Osei Ejako. I'll wrap up with him and then I'll return to you so we shift the discussion further. So, Dr. Ejako, Dr. Sorry raised a critical issue that the option of cost sharing is just so that the NHIS can regulate those who would choose to abuse healthcare services just because they have the card. Is this part of the key thinking behind your suggestion that government should formalize cost sharing?
No, not at all. We are not talking about abuse of the system. It's one of the methods to check abuse of the system. It is also a method of recovering some of the money for people to pay for medical services.
That's right.
You see, and it is also called co-insurance. That's one name for it, co-insurance.
Yes.
You know, so it is just not to check frauds in the system. It is there to get money to support the system.
Right.
And there are so many different types of co-payment. We have the fixed sum per service, which some countries practice. Then we have a percentage over the overall cost for service, and that is also being practiced in certain countries. Then we have a combination of the fixed sum and percentages, which are also being practiced successfully in certain countries. And it is not because it is to check the abuse of the system. It is abuse of the system is one of the reasons, but it's supposed to collect some more money into the system.
More money to the system.
So that people who offer services can be paid.
Right, Dr. Ejako, I
beg to disagree that it is only to check the fraud. It is not. It is also supposed to bring in money into the system.
Right, Dr. Ejako, quickly, let's focus on a little on the fact that your members have not been paid for 7 months. Are you giving government any timelines for which you expect your monies to be paid? If not, then what happens next?
Oh yes, in the press conference we said we've given the facilities or those who are supposed to pay our monies to us. Currently, we don't know whether the money is supposed to be paid by NHI or by Ministry of Finance. All that we need is our money. And we are saying that we are waiting until the end of May. The end of April.
Right.
If by the end of April we haven't gotten our money, then as from the 1st of May, we didn't say we will stop working because we call ourselves self-financing.
That's right.
We've got to work to pay our people and pay ourselves. We have to work to pay Social Security deductions. Recently, some of our people have been taken to court for not payment just because we have not been paid.
That's right.
So the press conference, strictly speaking, is to get everybody who cares about health systems in this country
to do something
advocate
about
on
it
behalf of the private sector,
so that
to
you're
get our
paid.
money paid to us.
Right, Dr. Ejako, I'm afraid that we'll end it here. We're grateful for your time, and I'm sure we'll be pushing for your monies to be paid for you. So, Dr. Sorry, this is the same situation that faces a lot of health sectors in this country. With the introduction of the National Health Insurance, many of us Ghanaians were happy because we wouldn't have to go back to that painful situation of cash and carry to get health care. But now it looks like the NHS is suffering. Whilst government says that the NHS is doing tremendously well, opposition elements will have us believe the scheme is collapsing. So what exactly is the status of the National Health Insurance Scheme from where you stand as former director of the Ghana Health Service and obviously as an objective viewer?
Yes. The health insurance we run today has run into difficulty. But before I come to that, let me again respond to Dr.
Ejako.
The thing is that co-payment or co-insurance will bring in money, definitely. If you are to pay 100 cedis, and as part of that, you are to pay 10 cedis of the 100 cedis, definitely the provider will get part of the insured money. It is that basically its reason is to make sure that the insurer does not abuse, the person holding the card does not abuse the system. That is what it's for. But it will definitely reimburse part of the money. Now, you see, when we started the social health insurance, definitely we had seed money. We had to invest the money. I talked on it some time ago, or not long ago. You invested money. Many providers were not there, so the money could generate more money to be sustained. But as more people enrolled and more providers came in, that amount that was
invested
dwindled.
Yeah, that's right.
I believe by 2010, 2011, most of that has gone away.
That's right.
And what they do is that they now collect the money. They owe providers a lot. They collect the money, they are giving money, and they have to disperse it. Now, what we need to do, it is not that it has totally collapsed.
Yeah, that's right.
We still have the opportunity to sit down as stakeholders and look at what we can do.
Yes.
To make sure that, one, if the monies come in, that money is not used to service a debt. You see, when you look at the reimbursement process, it takes about 2 to 3 months for the health worker to generate the claim and to get it paid. While that is going on, the money that is collected is not sitting in some coffer somewhere, not generating money. It should have been invested
so that we get more for that.
You get money for it.
Right, Dr. Sorry, I'm afraid that we might have to end our discussion, but I'm very grateful for your time, and we will be speaking to you more on the issues of health as we progress. But on the other telephone line, I have Sidua Hall, who is a country focal person for Africa Platform for Universal Health Coverage. Mr. Hall, good evening, and thanks for your time. Right, I think we lost Sidua Hall. We're trying to raise him back onto the telephone line. But the discussion we are having today is based on the fact that the private medical and dental practitioners say they have not been paid money that is due them from the National Health Insurance Authority for the past 7 months. And they have given government up until May 1st to pay their money back to them, or they will be compelled to withdraw services to NHIS card holders and make it exclusively for those who can pay for the service. On the back of that, the private medical practitioners are recommending that government should adopt a co-payment system as well as take a critical look at the existing capitation policy and resolve all the lapses that are with it. Sidua Hall is back onto the telephone. Mr. Hall, good evening.
Good evening.
So we've heard a lot from the private medical practitioner. We also spoken to Dr. Osei, who both paint a certain picture that suggests that although the health insurance scheme is not collapsing, it faces a lot of challenges which makes it impossible for it to generate enough revenue, invest some of that money, and use parts to pay its debt. Do you see this as the major challenge facing our national health insurance scheme?
Well, thank you very much for your time, and good evening to our listeners. I do share with Elias story because if you look at the revenue streams of the national health insurance scheme, the basic trade, the 2.5% contribution and that of the premium. Now, we're supposed to really raise a lot of money from the informal sector through the payment of the annual premium.
That's right.
But you will realize 80%, about 80% of the population that are in the informal sector don't have 50% of that are paying the annual premium. So we have a lot of people in the informal sector who are still not contributing to the national health insurance scheme. So that is kind of like a deficit in terms of the expected revenue to the scheme. So that is one reason why the scheme is struggling in terms of revenue. However, there is also the challenge of the Ministry of Finance not making the money available on time to the National Health Insurance Authority to reimburse healthcare providers. And that has been a major challenge because I have people saying that because a lot of people came on board and the money wasn't forthcoming, the National Health Insurance Authority who is the healthcare provider. So when they collect the money, they are not able to invest it. They have to pay them directly. But in the way back to differ slightly, if we say that a lot of people came on board, then that has to be explained because if more people come on board, then we also expect the revenue to increase. But I think the many people coming on board, you have probably fallen in the exempt category. So they fall in the exempt category. It means that they actually not paying because of their status as indigent or probably under 18.
Right, so Mr. Hall, quickly, we don't have a lot of time. Mr. Hall, so if you look at these challenges which you have enumerated, do you feel that co-payment or cost sharing is the way to go in order to resolve these challenges?
I think it's a big no, and I think that I will understand why any person or any group of person at this point of time who is suggesting co-payment. Co-payment, allowing co-payment or agreeing to co-payment bringing back cash and carry. It was because we do not want out-of-pocket payment that we implemented the National Health Insurance Scheme so that nobody will be pushed into financial catastrophe or nobody will be denied access to healthcare.
But Mr. Hall, co-payment is happening. I mean, I go to the hospital with my father who has a national health insurance scheme. Certain services are covered by the health insurance card which he has. Others are not. And we need to actually bring out hard cash to pay. Otherwise, he doesn't get the medication, he doesn't get the treatment he needs and for which he went to hospital.
That's what I was coming to because I don't know the analysis that went into that proposal. Otherwise, already in the way, people with national health insurance cards are still paying for certain services that are not covered. So suggesting that we should bring co-payment is out of place. And it's something that I think that it shouldn't be even be up for discussion. Because what will it mean to achieve? Already we know that the national health insurance it doesn't cover everything.
So, Mr. Hall, your fear is that resorting to co-payment might take us back to the cash and carry we are running away from.
Absolutely, because co-payment is going to take us back there. Already, we are even struggling, and even with the current system, people are still even struggling.
Right.
Those with the national health insurance, they go to hospital and they still complain about certain causes that they feel that should be covered.
Mr. Hall, I'm afraid that we have to end our discussion. We don't have a lot of time. We're very extremely grateful for your time on today's Big Story. My name is Stephen Enti, and thanks to you all for staying with us. We'll be right back with an interactive segment. Do stay.